Okay, it's 1 o'clock. Go ahead and try this out. Thank you for joining me on Facebook. This is definitely new technology for me in this era of trying to do education based in web platforms. I'm also trying to improve my use of live streaming and use of things like Zoom. So that's part of this motivation. And then another part of this motivation to do this today is also, I think some of the graphs I put up in the past couple of days have been a little bit clunky. And I just wanted a chance to kind of talk through those for a few minutes and talk through some of the data and important COVID issues I've been looking at this week, and I think are going to be important coming into the weeks to come. First thing I want to do is I do want to give a shout out to Aaron Kersner. Aaron's a friend of mine who I've known for a very long time, who printed these 3D printed ear protectors. Essentially, they go back behind your head and then keep the tight rubber bands off the mask from pushing on the back of your head here on your ears. I wore mine all day yesterday during my clinical shift, and it was great. So thanks, Aaron, for doing that. Little things like that I know have kept the spirits up of a lot of healthcare workers out there to see that so many people are trying to help out and do these kind of things. Quick update on 3D printed items too. Let me see. Let me grab this here. I think I mentioned this to some of you guys, and I don't know if some of you or some of you are involved in this or watching, but these are our 3D printed swabs. Summer Decker's group in the radiology department has been working on these, and Michael Tang's group over in the USF Internal Medicine has created a viral transport medium. We have studied these in our patients. You hear all the time, there's like no testing, right? That's the issue. When we say no testing, what does that mean? It can mean you don't have a swab. It means you don't have the technology for the test. You don't have the reagent for the test. You don't have the machine, the manpower. So we actually have a lot of those pieces. But the piece that all hospitals, I think, have been a little stressed by is the actual supply of stuff, the stuff you do the test with, the test kit, which means a swab like this, viral transport medium, a little liquidy stuff like this. You have to have all that stuff to be able to do the test. And so we were getting pretty short on these swabs because of some supply issues coming from Italy. So we had these swabs made for us. We studied these for about a week and a half in our emergency department, and excited to tell you that we've actually moved to using these clinically for a lot of our patients now as well. So really cool from lab to bedside, moved pretty quickly. So just some updates there on innovation that's been going on around COVID as well. All right, I'm going to try to share my screen and talk about a couple of important concepts here. Let's see if we can get here and share, and then I'm going to go to this one. And hopefully my screen is being shared now, if this is working right. And the first thing I want to start with, I think, is a graph a lot of you have seen before on my Facebook page, and that is essentially our per capita standardized caseload over time. I've made the point that it's really important to think about per capita caseload over time because it standardizes a lot of that variation we see across populations, and we're able to compare populations. So not only that, a group of us, some people over in the USF Center for Business Analytics, myself, some of the TGH folks, have been working hard on trying to figure out how to use some of this data to model. And the basic concept of what I've been doing to model is this idea that some places are ahead of us in terms of their outbreak. So down here on the x-axis, this is like the number of days the outbreak's been going on. And you can define that different ways. Like you can define it by the number of cases. You can define it by a logarithmic scale, looking at like how the virus moves through the population. Here, we just kind of think about the load of cases, cases per 100,000 people, which is a pretty common public health way to think about the load of disease. And so how far are you in this epidemic? What turns out to be pretty interesting is the growth rate curves all look kind of the same for whatever population. The virus does the same thing in whatever population it goes to if left alone to do that. So we can use this x-axis to think about the time the virus has been out there moving through the population. And so what's been really interesting is you see like totally different caseloads in different areas. And so this is explained by a lot of things. This is explained by just what does the population look like, right? So I don't have New York on here because New York just like dwarfs all of these. But if I had New York on here, New York would be like a vertical straight line going up. So it's just not useful to put on here because it just destroys the graph. But right, New York's a very dense place. And so it looks very different. Miami-Dade is a very dense place. So it looks different than the rest of Florida. So that's part of the explanation. Other things that you can start to think about, though, is there something that's working well in terms of the interventions that you're trying? We call that group of interventions non-pharmaceutical interventions, things like social distancing, closing down buildings, closing down workplaces, what we're doing right now, safer at home. So you can start to ask, did that stuff work? So South Korea is a great example. South Korea, and we're going to come back to South Korea in a few minutes in the talk, but South Korea is a great example because really the first case was at the same actual date. These are standardized days, but the first actual date in the US and South Korea happened around the same time. And you're able to see it basically over time, South Korea has been able to really minimize the impact of that outbreak in their population. They had almost a flat line the entire time. So very different mitigation strategies there compared to the US, which has had essentially 50 states of various types of strategies employed. So one of the things I say all the time, which I think is important to talk about, is that overall what we're seeing is a gigantic randomized controlled trial of public policy that's happening throughout the whole world and within the country as well. You'll never see this again, and you'll never be able to get this type of data to figure out what the right thing to do is in the future. And what I would like to say is it's pretty clear now the right thing to do is some type of social distancing. What I think we're still trying to figure out is how much of that social distancing do we need? Let's go back up to an example here. For example, Pinellas and Hillsborough look about the same in terms of their slopes, right? Their caseloads look about the same. Both are lower than Florida, and both are overall actually doing pretty well. They've kind of flattened out their curves, but they did take slightly different approaches to social distancing. Most of the municipalities, most of the cities in Pinellas County actually kept their parks open. Hillsborough County did not. So in the future, can we think about, do we actually need to close the parks, or maybe we could keep those open as long as we enforce the same social distancing ideas in those parks that are open? Those are the kind of things I think we have to start to drill down on and have some responsibility to drill down on, given this data set that's being presented to us. While we're talking locally, one of the really clear phenomena that we're observing right now is Hillsborough County has plateaued. So I don't think there's like a peak like hiding that's about to come. I don't think, I'm not even sure this is a peak. It's just a plateau. We've hit the plateau. The other thing that's important to talk about with Hillsborough County is that the social distancing measures we did do, they clearly paid off. They paid off in a way we can measure. So what I mean by that is if we expect to start seeing results of social distancing about 2 weeks after they're implemented, that really starts to happen around day 14, day 15 in Hillsborough County. We see a slope bend. Then we actually see another slope change right around here. If we kind of zoom in on that a little bit, we did see another slope change right around here where we intensified those City of Tampa and Hillsborough County social distancing measures. And those both, I think as researchers, as educators, I have to make the case, and it's important to tell that story, that there is clear evidence here that what we did back here paid off up here. So there is an impact of social distancing that we can see right here. And I think that's an important thing to make sure people understand that narrative. The reason we plateaued isn't just by chance. It seems to correlate pretty well. If I wanted to explain that variation, the hypothesis I would use is that, oh, look, those things we did 2 to 3 weeks ago, a month ago now, really seem to have mattered. So what's going on with the other places? Let's take a quick look at those. Italy's another place I had originally started using in a data-driven sort of nearest neighbor modeling kind of way, because if you look back here for the first few weeks of the outbreak, Hillsborough County sat right on top of the Italy curve. And then again, when those social distancing interventions should have come into play, should have seen an impact on our numbers, we did, and we fell off the Italy curve. So this is a way to measure the outcome we're interested in, which is, did the social distancing work? And again, I think this outcome is pretty clear. So fortunately, Italy does seem to be plateauing as well up here. I talked about Singapore a little bit. Miami-Dade has some difficulties I've talked about, which is different looking than other areas in Florida. What's going on in Singapore? Singapore is culturally interesting. Singapore was lauded as doing a really good job overall with their public health measures. And they actually probably did do a pretty good job overall with the mainstream population's public health measures. What they kind of forgot about, though, is there's other people besides the mainstream population. They kind of forgot they have a large group of Malaysian immigrants who come in to work. They sort of ignored that population and realized there were some clustered outbreaks going on in those populations. They started to sample those populations more and realized there's actually a pretty high prevalence of disease there. So what we're seeing in Singapore is probably not so much due to relaxed social distancing measures. That is a problem in some countries we'll talk about in a second, but probably more so to undersampling their population. Undersampling is important. People definitely have a hypothesis out there that we're doing a lot of undersampling in general, that these curves don't actually represent the amount of disease that's actually out there. I'm going to fight against that. I'm going to push against that a little bit as I go through this. I think overall, especially in the US and Florida and Hillsborough County, I think these actually are pretty good reflection on what we actually have out there in terms of true disease. And I'll come back to why I think that in a second. But Singapore, down in here, day 30, 40, this area right here, this was not a good reflection of what was actually going on in terms of the amount of disease in the population, because they were missing a big chunk of population by poor sampling technique. Okay, so we'll come back to a couple of those concepts. I think the big story today is Georgia. So Georgia did move ahead with reopening some of their businesses. Some interesting ones like bowling alleys, definitely not a place where you're going to do a lot of social distancing. You're going to have to touch a lot of things other people have touched. Hair salons, by definition, can be close together, gyms as well. So some interesting businesses to pick to start with. So why did Georgia reopen? Well, I don't know is the answer, but let's talk about Georgia a little bit. What should a state do to reopen first, I guess? So the first thing you would want to think about is you have to have a really good idea that the data you're seeing reflects reality. Okay, so that's super important. What does that mean? It means that you think that the prevalence that you are reporting by diagnosed cases matches what you see in if you're actually to go out there and test everybody with a test that was, reliable, had a high positive predictive value, all those things. Well, I think overall, Georgia probably is representing reality by their testing at this point. I think there's enough testing going on per million that what we see is probably reality. But here's the thing, reality is not very good for them right now. Georgia's in worse shape than Florida. Georgia actually has an upgoing curve still. Cobb County, Fulton County, those places don't look great. So their cases are still rising. You wouldn't really argue this is a plateau quite at this point. So overall, Georgia's kind of that same trajectory as the United States, still heading up a little bit, not fully plateaued. But even if you had plateaued, let's go back to Hillsborough County for a second. So we've kind of plateaued now. We've been at 70 cases per 100,000 for the last 6 days in a row. So we've plateaued. So what does that mean? How would you, if you wanted to consider how you would go about relaxing social distancing, you would need to have a very clear coordinated approach in place. So for example, you might have automated technology like cell phones information that tracked positive patients and people around and let you know when you were next to a positive person. I'm going to come back to that in a second. Biological surveillance with antibody testing, rounding on people and having them do diagnostic testing in groups and neighborhoods and populations. Some strategy to know where disease is at and get a hold of disease very quickly. That's not where Georgia is, but it's interesting for the model. I'm glad they're ahead of us. I'm not necessarily glad they're doing it, but it's interesting that they're doing it because it gives us some important data to see what this is going to look like. And that's data that we do need to understand what would happen if you reopen without having any strategy set up. That's what we're going to see from Georgia. We'll see scaled reopening of big public areas with no coordinated strategy of how you surveil. Okay, I'm going to move to Sweden for a second. Sweden's also been in the news, and Sweden's important to talk about because they also have a different strategy. Unfortunately, one of their head epidemiologists actually said that their goal was to reach herd immunity. And look, it's not crazy that you might have a goal to reach herd immunity, but that would have to be a very coordinated effort with understanding, again, of what the prevalence in the population is and how you're going to get to herd immunity. So what is herd immunity first? Let's just mention what that is. So not to get too into the math of things here, but we know overall that COVID, every person who gets COVID can infect about 2.35 more people. All right. So every person who has it's going to infect another 2.35 people. That's called R naught. That's what this R0 symbol is up here. So R naught. So the formula to figure out herd immunity, that means the number of people in the population that need to have the virus where it'll stop moving around and being transmissible is R naught minus 1 over R naught. So we just do the math here. We got to get to 57%. So that means 57% of people in Sweden need to have COVID for it to stop spreading. Well, that's going to be really hard to do because right now their prevalence is probably less than 3%. And if you really want to push it, if you really want to say that, you know what, I think there's a lot of undiagnosed disease out there, which I'm going to criticize in a second. But if you really do want to say that, and you even think it's much higher, in the Santa Clara paper that came out this week, it was, got to 4%. Even in the New York paper that came out yesterday, they got to, I think it was 20% right in the city and 3.5% in the upper part of New York. So you would still have, from even at 20%, you have to get to 60%, right? So 3 times more infections. And right now, Sweden has the highest caseload of all the Scandinavian countries. So this, and just I should back up too and say that what Sweden's doing right now is a strategy of much less social mitigation. They're doing much less social distancing in their mitigation strategy. They have some, but not a lot. And is that working? Well, from a caseload perspective, it's not working. Now, if you were going to go at a herd immunity strategy and you thought the pathogen you had was benign, then maybe you let this curve ride up. Maybe you let this curve ride up to 60%. Let this caseload keep on going up until you get there. Before I leave this slide too, I should mention Denmark's also an interesting place because they were doing reasonably well, but also on their slope up, they chose to reopen schools. So again, this is a once in a lifetime opportunity to gather data about different public policy interventions that have clear before and after points in time that we can see what does that social distancing strategy or public policy change in the cases we're seeing, the population we're seeing. So Denmark's also interesting because we can watch and see maybe we can open some schools and maybe it's not going to change the curve. So it's interesting to watch that. Back to Sweden for a second. So caseload's very high in Sweden. Hey, if it was benign, who cares? But here's the problem. It's not so benign. Right. So in reality, the case fatality rate in Sweden right now was climbing. It's about 12% over the past week or so, 2.5 times the Denmark case fatality rate. If you average this case fatality curve for Sweden over the last 30 days, it's about 6.5%. So it's pretty high. So you can't make the argument that everybody's just doing fine in Sweden, so we can just ride this out till we get to herd immunity. What you're going to see are a lot of deaths. That's what's predicted right now in Sweden if we keep on riding that out. Now, I think culturally, Sweden has got to deal with this because I think culturally they're basically the feeling I think I have right now going on with Sweden is that, hey, if it's a deservingness issue, right? If it's the immigrants and the poor and the elderly that are dying, maybe we don't get too concerned about this. So I think we have to really watch that explanation of who's dying, who deserves to live, that may explain some of the continued social distancing practice towards herd immunity, even in the face of high case fatality. Okay, I'm going to turn away from the epidemiologists for a second. Just want to talk about other couple important things out there right now. One of them is this paper. There was one thing also to look for when you're seeing all these papers come out. If you see this MedRx4 thing up here, I'm not saying don't read the paper. They might be interesting papers, but understand these are not peer reviewed yet. This is a group of scientists have written a paper together. They've stuck it up on a preprint server so other people can read. This is not peer reviewed. This is going to be, I'm going to tell you why that's important in a second. This paper, though, is peer reviewed, it is published, and you can download it, and it's free and it's easily available. But I think it's just a nice way to think about the pathology of the virus, and it's a pretty pictorial way to conceptualize it. So you have sort of 2 phases how people get sick from this virus. One is the viral response phase, and then there's this host inflammatory response phase. This is how we target our medications, okay? So some of the medications we're targeting are about the viral response phase, and some are about the host inflammatory response phase. So these medicines end with words like MAB, so like anything that ends with the MAB, those like monoclonal antibodies, they're kind of focused, on this phase to try to take down IL-6. Some of the medicines like remdesivir are more focused on this viral response phase, so actually antiviral medications. So just it might help you to sort of understand how to think about and conceptualize the large group of medications that are being talked about right now. Ideally, when we get there, we have some kind of multi-viral response medication treatment and maybe multi-host response treatment. That's what I think everybody's working towards right now. Okay, I'm going to go back to the testing issue for a second. So one of the important questions I want to tackle today that's out there right now is there more disease in the population than what we've diagnosed? We know testing's a problem, so maybe there's a lot more disease than that. So first of all, I will unfold that I think in most areas of the country, what we see diagnosed represents pretty well how much disease there is out there. So why do I say that? Well, one, it's the benefit of working clinically. Like I know what I see clinically, right? I know what's been coming into the hospital. I know how many cases I've diagnosed. I know how full we are of COVID patients or not full we are of COVID patients, right? So I can say, yeah, this seems to match the Hillsborough County curve. I feel like we're kind of flat. There's also another important database called the Essence database, which is the state's epidemiology monitoring database for cases that come into the emergency department of chief complaints. So things like, do you come in with cough or shortness of breath or fever? It watches how many patients come in with those types of complaints. We've been pretty flat. We saw a spike in March and we've been pretty flat. There's not like a bunch of occult cases of this going on. Doesn't mean you can have asymptomatic people out there, but not a lot of occult cases. Now, the other interesting thing is, though, as we start to consider testing of healthcare workers, testing of asymptomatic medical patients, we also don't see a big spike in the number of positives out there. So overall, I feel like at least in our area in Hillsborough County, but also in non-big clustered outbreak areas, what you're seeing in diagnosed cases probably matches pretty well what's actually out there in prevalence. So let me go to the New York paper and the Santa Clara paper. This is the Santa Clara paper that came out earlier this week. And it basically said, hold on, I think there's a lot more virus out there that's actually being diagnosed. So there's a couple ways to think about diagnostic testing for this virus. One is the nasopharyngeal PCR. That's that plastic swab I showed you a second ago, right? Or, standard care swab's got a cotton tip, but this goes back into the nasopharynx, tries to get some viral RNA, brings it out, amplifies that viral RNA, and you measure it. It's a very good test. It measures it, tells, if it's positive, you probably are shedding virus, okay? The other way we can think about measuring and diagnosing patients is by antibody testing. There's actually two types of antibody testing. The media is not doing a good job of describing what they're talking about when, but one type of antibody testing is like testing you when you're sick. Right now, you might look for like the IgM antibodies in somebody. There's another type of antibody testing just to surveil whether you've been exposed to the disease before. For example, when you get a vaccine for something, it's going to eventually raise your antibody titers. There's like your IgG antibodies. So if I'm talking about testing people right now in the hospital, I might do an IgM type of test. If I'm talking about serology screening, I might do an IgG type of test. So and you're just now starting to see IgG tests come online. It's kind of a new technology. So this paper here is a paper that, again, is not peer-reviewed, but is sitting there on a server. And the basic argument of this paper is that, hey, the prevalence of this disease is underrepresented by the diagnosed cases. And if we go out to the community and we sample a bunch of people, a whole bunch more people have antibody than we actually saw. So we should actually scale up our numbers by 10 times, 15 times, 80 times. There's a big confidence interval around this. Actually, the critique from the Stanford group is around the confidence interval. I won't go into math of this too much, but no matter where that confidence interval ends up going, the argument of the paper is there's a lot more undiagnosed cases than are diagnosed cases. So I'm going to do another talk maybe soon, maybe next week, on this idea of positive predictive value, but understand this plays into this heavily. And I'll just say this for now: if the prevalence is low, and when I say low, 3%, 2%, that's a pretty low prevalence. If the prevalence is low, the positive test means less. It means less clinic. It does not mean you have disease. And the more prevalent the disease in the population, the more likely a positive test means you have disease. So I'll unpack that at I could do a whole other one of these on that, but just understand that for now. So low prevalence means I can't trust these antibody tests quite as much right now. It's almost like a flip of the coin. But even if you take a high undiagnosed to diagnosed, this only moved us about 4% prevalence. So still pretty low prevalence overall, which goes back to the Sweden argument again for a second. And the reason I say it goes back to the Sweden argument is because even if the prevalence is much higher in Sweden than the 1.5% or so that we actually see, even if you go up to 5%, remember, you got to get 57% to get herd immunity. So again, it's still a lot more people would have to get disease, and given their case fatality rates, a lot more people would still likely die as they move towards herd immunity. All right, that's enough on the maths around that for now. I'm going to unpack that more next week when I talk about positive predictive value. I do want to just introduce this podcast really quick. I think this is worth a listen. So one of the things I've tried talking to people about is that as we ramp up, we have to think about what surveillance strategies look like. So it's probably, since we're clearly not going to have a nationally based, well coordinated federal strategy. So we probably have to do this like at our local institutions and scale them up, hospital, university, county, keep scaling up. How do you do this? Well, it probably involves some level of serology antibody screening. So maybe bringing all your healthcare workers, you screen all of them. Maybe you start screening all the patients. Maybe you start testing all the patients, testing all the healthcare workers every once in a while. I mean, that's how you keep your hospital safe. Maybe you do the same thing in a university or school. Maybe you also bring in automated technology and manual old-fashioned contact tracing. So when I say old-fashioned contact tracing, the best example of that probably comes from the WHO's DOTS therapy program. So that's where people actually went and watched other people take TB medicines when they had TB. So manually going out and doing this. So manual contact tracing would be like actually, understand who has disease, where they are, keeping that person isolated, taking all people who are exposed to that person, really contact tracing them, making them aware they were exposed to somebody and doing screenings of those people. We don't have the manpower for that right now, but there's some debate out there as to whether you start to repurpose people who are unemployed into that role. Now, at some level, though, you probably want to start thinking about automated contact tracing, right? So obviously, Facebook, our phone, all these things have a lot of data about us. How we want to use that data is a society question we have to get into a conversation about really soon. So not that I'm necessarily advocating for this approach, but I think this approach is important to hear. This podcast is about an American living in South Korea and sort of his experiences with their automated contact tracing that's being done with a cell phone app. So you can start to think about how this could be done. And, you go to a restaurant, somebody at the restaurant tests positive, your phone knows you were there. It tells you even where that person was sitting. You can think about where you were sitting, were you close to that person or not. That's the level of detail some of this contact tracing is taking place. So I think it's worth listening to that podcast. Another thing I really am harping on is that as we start to get more data, as we start to see more data from these curves, we can see the effects of social distancing on our outcomes. That's a really important concept because we can't lose sight of the fact that social distancing is working, and we have data to show that. We have data to demonstrate that. So again, the Hillsborough curve being flat for 6 days, timing perfectly to the time we had social distancing strategies. That's what this paper is from MIT. They both modeled this and tested it, and it just verifies the fact that social distancing strategies in places that did them, the intensity of those levels of social distancing clearly paid off in the outcome curves. Then some of you may have seen this as well. This is published in Lancet this week, and this is just shows you how easy it is to spread this virus, the high R naught, that's that transmissibility number. So in this model from South Korea, and again, this is something you can never do in the United States right now. This level of contact tracing is something we don't have. So for them to even be able to put out this looks like a phylogeny tree essentially, but to be able to put out something like this is like way beyond where we're at right now. But the contact tracing is so intensive in South Korea, they could do this and they could get a hold of it, cluster these people and keep the virus from spreading. But here what you're seeing is basically you got 2 travelers from Wuhan, they go to a church service person is infected or infects a couple of people at this church service. One of these people then go to a family gathering. They infect a couple of people, a person for the family gathering then goes out and infects basically another church service. And all this is the entire phylogeny of where all the virus came from in South Korea. One interesting thing is they note in the paper that this person right here was actually tested on a serology sample, a blood sample, which we're really not doing much of at all, really at all. The reason for that is because some early papers demonstrate there's not many people with viremia, which means the virus is actually in the blood. So we haven't really seen much of a reason to do that. There are cases, though, of people who don't have a positive nasopharyngeal swab because the virus is lower, like down the lungs, and so you have to test the lungs instead. But it is interesting that South Korea did this blood test in this patient and got a positive. So just shows how easy the test spreads. And I think I'm going to save positive predictive value for a whole nother one of these. And I think I'll stop there, but those are some of the big issues I think going on in COVID right now. I'm going to take a look. I see there are some people on here and see if there's any questions on Facebook. It looks like just some comments. So thanks for bearing with me on that. Some new technology there, trying out some of the streaming and Zoom features. Hope that was useful and unpacked a couple of those difficult concepts. Thanks.